Is this correct?
Yeah, exactly. The basic aim of my presentation is that where is the data right now and where we are standing right now. So where we are deficient and where we have to move further. So starting from my presentation, this is a cardiogenic shock, role of mechanical circulatory support. I am Dr. Mohammad Waqas Mazhar. I'm working as a consultant interventional cardiologist in Fahad Hospital, Tabuk. So as you know, there is a sky shock classification, which is a certain grades of shock. This is grade 1, A, B, C, D, and E. At grade A, you know that the patient is stable, who is not experiencing any signs and symptoms of shock until unless there is a large AMI or decompensated heart failure. And progressing to grade B is a beginning in the patient is having a hemodynamic instability with hypotension, tachycardia, and abnormal systemic hemodynamics without signs of hyperperfusion. In grade C, it's a classic shock, and the patient who has developed clinical evidence of hyperperfusion that initially requires pharmacological and mechanical circulatory support. Similarly, if it progresses more to deteriorating and grade E extremis. In deteriorating, there is a patient who is having a classical evidence of shock that is worsened or failed to improve despite escalation therapy. And finally, there is a refractory shock with actual and impending circulatory collapse as well. Moving forward, the early identification of shock is very important. So from these gradings, stage B, grade B is very important because if it may worsen into grade E or D or E, and once it worsen to grade D or E, the mortality is very high. So always aware that the patient is in which stage, grade stage A or stage B. The longer the patient is in the shock, the worsen is the outcome. So according to this Sky shock classification, the survival rate and time of onset of shock with the onset of mechanical circulatory support. If the support is initiated earlier, within less than 1.25 hours, so survival will be 66%. And if it is delayed in between 1.25 to 4.25 hours, survival is 37%. And if it is more delayed than 4.25 hours, then the survival is 26%. So this is the clinical parameters like of cardiogenic shock, systolic blood pressure less than 90 millimeter of mercury, along with inotropes, cold clammy, tachycardia, lactate levels are going to high, more than 2 millimole per liter. ECG, there is evidence of STEMI or unSTEMI, echocardiographic findings, and pulmonary artery catheterization with these criteria. Cardiac index less than 2.2 liter per minute per meter square, and pulmonary blood pressure more than 15 millimeter of mercury. This is a very good expert consensus statement, which was published in Euro Intervention Journal in 2025, in patients who are having a high risk percutaneous coronary intervention, in patient with reduced LV ejection fraction deemed not suitable for surgical revascularization. And according to this expert consensus statement, they have characterized.
Yeah, but excuse me, Waqas, this is a little bit out of topic. So this is a high-risk PCI consensus. This is not a cardiogenic shock.
Actually, just I will make a comparison between these two things because sometimes we are facing acute MI with severe LV dysfunction, and sometimes
yeah, but that's high-risk PCI. That's different. High-risk PCI is one thing. I mean, mechanical circulatory support for high-risk PCI, high-risk PCI is one thing, and MCS for cardiogenic shock is another. So there are two different topics of application of MCS. This is my comment.
Yeah, this is you're right, exactly. But sometimes when we are doing acute MI, I will show you for a few cases which we faced acute MI and there is a high-risk anatomy and high-risk PCI. So high-risk anatomy, so it will be a high-risk PCI with cardiogenic shock as well. So I'm comparing both together, combining both together. Can I proceed or just I will skip this two or move further?
No, I mean, I want to dedicate the lesson for MCS on high-risk PCI. Okay, so if you want to go a little bit superficially on that, it's fine for me. It's not a problem. But your focus today is cardiogenic shock.
Yeah, exactly. I will just I will be rapid from these slides and we'll go further. So just briefly, according to, they have compared two trials, Stitch and Revive BCIS-1-2 trial. So there is a no significant, in all the including criteria in these two trials were patient with LV ejection fraction less than 35% and extensive coronary artery disease. The only difference between these two is that in Revive BCIS-2 trial, there was a myocardial viability was done. So in conclusion, there was no significant difference between medical therapy alone and medical therapy plus CABG in patient with stitch trial with respect to all-cause death. And also, there's a one limitation. They have used a younger age group with a mean age of 60 years. And on the other hand, in the Revive BCIS-2 trial, PCI, in addition to optimal medical treatment in patients with severe LV dysfunction and coronary artery disease with viable myocardium, did not significantly improve overall mortality or rates of heart failure hospitalization. So PCI with optimal medical treatment was not superior to optimal medical treatment alone in improving LV dysfunction. In this, there's a limitation. They have slightly taken the older population, not revascularized by CABG. So just moving forward, according to this expert consensus statement, balloon pump assisted coronary intervention study BCIS-1 investigated elective IABP support in patients with LV ejection fraction less than 30% and severe coronary artery disease. The trial did not show a reduction in composite endpoints with IABP placement before PCI in severe LV dysfunction. So what is the express consensus statement in this? At this stage, they decided that selected mechanical circulatory support device should be representing the least invasive one and hemodynamically adequate device. So retrospective analysis suggests that VA ECMO is extremely invasive, while intra-aortic balloon pump may not provide sufficient hemodynamic stability in some cases, making microaxial flow pump a suitable choice in most situations. So I'm moving forward with this. There was another expert consensus document from the on percutaneous ventricular assist device in and their results. Indication for percutaneous ventricular assist device support in high-risk PCI. Intra-aortic balloon pump, as far as it is concerned, should not be used according to BCIS-1 trial. Microaxial flow pump, there is maybe considered in highly selected patient undergoing high-risk PCI in case of acceptable femoral access with common femoral artery diameter more than 6 millimeter and not severe toxicity. This is according to PROTECT 2 and cohort studies. While on the other hand, VA ECMO should not be used. There is no definite data available. So PCI might be considered as high risk in patients satisfying the following criteria, in which there's a clinical characteristic of stable or decompensated LV ejection fraction less than 35% with hemodynamic instability, diabetes, acute coronary syndrome, previous cardiac surgery or chronic kidney disease, and severe coronary total occlusion, severe calcified lesions needing rotational atherectomy as well. So moving forward, there's what about the indications for percutaneous ventricular assist device in cardiogenic shock? According to IABP Shock 2 trial, routine use of intra-aortic balloon pump is not recommended. Maybe it's used in patient with mechanical complication with acute MI or in non-AMI related shock. While as compared to a microaxial flow pump, there is a small randomized study which conclude that Impella CP may be used as a short-term therapy in cardiogenic shock with stage C and D with potentially reversible underlying cause. And on the other hand, VA ECMO may be used as a short-term therapy in cardiogenic shock with stage C, D, and E, particularly in patients with combined respiratory insufficiency with potentially reversible underlying cause, transplant, or VAD, ventricular assist device candidates. Maybe it is used for selected patient in refractory cardiac arrest as well. So there is also there is another indication for percutaneous ventricular assist device in high risk AMI without cardiogenic shock. Even in patient without cardiogenic shock, IABP is not suggested. So according to CRISP AMI and PAMI 2 trial. And similarly, in a as far as microaxial flow pump is concerned, Impella CP use seems feasible as a preventive unloading strategy. Currently, there is no data showing on advantage for this approach. This article was published in 2022. It's a 3 years before. Now we are moving forward with certain new randomized control trial like a danger shock trial available with us. Now moving forward, as compared to VA ECMO should not be used increasing afterward in the setting of acute coronary ischemia might be harmful. So there is no definite data available. Now I am presenting, I will present quickly these two quick cases. In our center, we are doing mostly we are having intra-aortic balloon pump. We don't have a facility for VECMO as well as Impella with us. So this patient, case number 1, he's a 65 years old gentleman. He came with acute anti-wall MI and he was in severe cardiogenic shock, stage D cardiogenic shock. And we started inotropic support. We inserted intra-aortic balloon pump and there is a high risk anatomy, like a Medina 111. And there is a thrombus with a heaviness in the distal left main stem as well. So we proceeded with this high-risk anatomy and IVP assisted T and pertusion, bifurcation stenting at in the end, and there we were successful and procedure got completed. And there is a slow flow. Initially, we put the patient on ventilator, and later on, this patient didn't survive the hospital admission. Similarly, I have another case. This is a case number 2. This patient came.
Wait a second. Come back to the previous one. So the first case, you did a complex left main stenting, if I understand well.
Yeah.
Can you come back to the previous one?
Yeah, just a minute.
So my question is, how long was the procedure and how much contrast did you use?
Just a minute. Yeah, procedure was prolonged. Actually, we use almost 250 ml dye in this case. It was slightly prolonged procedure, and almost 2 hours. We spent 2 hours in this case because of unstable hemodynamics, as well as patient was in failure as well. We put the patient on ventilator before initially after angiography. We decided to put the patient on ventilator because patient was not so much sportive. Hemodynamics were not so much sportive.
I think that without Impella and only with balloon pump, because you didn't have Impella at that time, it would have been difficult to, to save his life. My suggestion in these cases would be to reopen the vessel, keep it easy, then keep it easy, and then keep it simple. And then in the end, keep it simple. Okay. So my suggestion is never to do complex bifurcation. You don't want to have a perfect kissing balloon, perfect stent position. Here we are dealing with saving the life. So you reopen the vessel, you put one stent, you reopen the side branch, you go away. You do that with 60, 70 of contrast in 20 minutes, 25 minutes, and then you have more chances of saving his life. This is important. The more complex you go in these patients, the more contrast you give, the worse it is for them.
Yeah, exactly. I agree with you.
Because I had some comments also. So one question is, did you put the balloon pump up front or did you put it just prior to PCI, or when did you put the balloon pump?
Yeah, it was after coronary angiography. After coronary angiography, this was we concluded that this is a high risk anatomy, and without balloon pump support, we cannot perform PCI in this patient. So we did upfront balloon pump before PCI.
Yeah, so I agree with Prof as well. I think, in this sort of anatomy, you would wire the vessel. If there's thrombus there, maybe aspirate, and then very gently balloon and then deploy a single provisional stent, maybe a gentle pot. And then you can always come back later on to optimize and to fix side branches, That has been my experience as well, because the more you do, the more sort of distal embolization they get, the more sort of injury they get, particularly to the microcirculation, and they tend not to recover. So I agree exactly with Prof. I do exactly the same thing. You try and keep it as simple as possible. 60, 70 mils of contrast. If you can get ECMO or Impella up front, your chances of survival are better. But maybe not ECMO now based on current data, but Impella, if you can get it up front, then maybe, there's a chance there. But tough case, and yeah.
Yeah, we discussed later on in our mortality meeting as well. And we concluded that it is better to be quick and less invasive rather than becoming more invasive and aggressive in this case. So just putting a small stent LMS to a lady and just later on restore the flow and just coming back again. Later on, once the hemodynamics became more stable. So next case, he's a 50 years old gentleman. He came with history of, he's a diabetic, he was hypertensive, he came with acute anterior wall MI and cardiogenic shock. He was in severe shock. We took him to the cath lab. And in the cath lab, same anatomy, high risk anatomy, he was having a thrombus in extending from the left main to LAD. LAD was total and circumflex, or there also haziness and the ostium of the circumflex. And in this case, we finish up with the culotte bifurcation stenting, bailout culotte. Actually, we did the provisional stenting, but there was a thrombus was still there and at the level of the circumflex ostium, and ultimately we converted it to culotte. And again, slow flow in the end, we were having only IVBP. And this patient survived the hospitalization, but later on, he arrested due to ventricular tachycardia due to severe LV dysfunction. And we were having a plan.
Same comment that we did for the previous one, I think can be applied to this one. Yeah. So you have to save myocardium, save life, go fast, and don't do too complicated things.
Exactly. So now you see, sometimes we are facing across the high risk anatomy along with cardiogenic shock. So two things together. So this is what you have explained already, that we need to be very simple and quick during the acute MI. So there's a need for microaxial flow pump. There's a new trial, which is a danger shock trial, which is it was conducted in 15 centers. It is a multi-center randomized controlled trial, which was conducted in Denmark, Germany, and UK. They assigned the patient with STEMI with cardiogenic shock to receive Impella CP plus standard care alone, or versus standard care alone. According to danger shock trial, the results were patients who died from any cause with standard care alone, mortality was more than 50%. And in Impella, in patients who were using Impella CP with microaxial flow pump and with standard care alone, there is a marked reduction of mortality up to 40 to 45%. So they concluded that routine use of Impella reduces all-cause mortality at 180 days in AMI cardiogenic shock due to STEMI compared to standard care alone. Now, according to ABiomed, they have
Can you come back to the previous one? So, which is your comment? You are deep. If you describe a study, and this is a landmark study. This is a very important study, which came out, I think, end of last year and was published in the New England, as you write here. You have to dig into the trial with you just told us the main information, the main message from the study, but there are also drawbacks. Okay, so yeah. I would like you to comment on the main drawbacks from this study.
There is one limitation which in patients with severe cardiogenic shock, sometimes they arrested within the hospital, and after that they did the PCI, and some patients got comatose, they the brain insult. So these patients didn't survive even with Impella as well.
But if I remember well, in this study, they excluded comatose patients, differently from other studies.
Yeah, they did. They excluded. I guess
I think it's wise. I mean, in the other studies, there is a study. I don't remember the name. Sorry, but the study with the ECMO. And then the old study published in 2012 or 13 with counterpulsation, IBP.
Yeah.
So they included this type of patients. In this study, they probably were wiser in excluding them. And this is one important message that can derive from this. The other thing is, if we want to comment on the significance of these, they were quite lucky. You can see the CI. CI is arriving at 0.99. I mean, I mean, if they with the flattening of the curve in the Impella CP, if they had assessed the same outcome maybe 7 days or 10 days before, maybe this could have been 0.56 to 1.02, and that would not have been significant. So this is barely significant. But that said, it's an important study. Another limitation of the study, if you read it, because I always say that if you discuss about the study, you have to read it. You don't have to read the abstract. You don't have to read give a look at the central illustration, but you have to read the study. If you can see that, you see that the enrollment period of this study is huge.
10 years. 10 years.
10 years. Exactly,
Yeah.
Bharat. Exactly. 10 years. So 10 years means that, okay, they had to open new countries. They had to open
UK.
Germany and UK. Yes, exactly. So they had to open new countries. So this means that the selection process of patients for this study is huge. And one information that I don't have, but it's an important information that we should dig into, is how many patients were excluded. Do you remember the Courage study? Courage study is a study published 10 years ago saying that in elective cases, PCI is not doing, that well. If you see how many patients have been excluded, and if you see how many patients have been, of the screened ones have been included, you see that that was around 6 or 7%. So, which means that what do you do to the other patients that are coming? The other 93, 94% of the patients. So when you analyze a study, it's very important to understand which is the setting, how many patients, and this message to how many patients can be applied. That's my comment on this study.
Also, there is certain like data on race and ethnic group was also not included or not collected in this study as well. This is one of the other limitations for this study.
Yeah, I think Prof is right. They screened, I think 1,200 or 1,300 patients and included 350 patients. So 75% of the patients were excluded. So it's not, 5 or 6%. It's about 25% were included. And the other thing that I think Wakas didn't mention was that in the cohort with Impella, they actually had more renal replacement therapy. So that was a bit, why did these patients, was it due to more contrast use? Were they doing more culottes and NP stenting in the Impella group?
How much contrast? Which is the difference in terms of contrast dye?
I can't remember off the top of my head. Let me look, yeah. Because
that's the first thing that you should assess. The second thing is that we are not, so when you do PCI and you assess the renal function, it's not a matter of contrast dye damage, it's a matter of AKI. So AKI is an omnicomprehensive cause for renal failure. We published a study. We published 2 studies showing that the transfemoral approach is associated with more renal complications as compared to the radial. The first study was a collaborative retrospective study. I was the senior author for that. It's called the PRIPITENA. And it's a big number of patients, but retrospective. And that was the basal. And then we published the AKI matrix, which is the pre-specified sub-analysis of the big matrix trial. We published it in JAC. And so that study is showing that the transfemoral access per se, independently of the usage of contrast dye, is associated with more renal damage, which means that probably if you pass in front of the renal arteries with a catheter, at least this is our hypothesis and interpretation, and this applies more with the large bore accesses like the Impella one, you may dislodge some atherosclerotic plaque, damaging the kidneys.
There is one more thing. While we are doing high-risk cardiogenic shock patient with acute AMI, and we are taking the patient who is candidate for Impella or or VECMO, sometimes cardiac arrest, they due to hypoperfusion, renal acute kidney injuries is inevitable. I guess, because most of the cases, whenever we are doing these cases, acute kidney injury is inevitable. So we cannot stop, or we cannot blame that this is due to hypertrophy, or this is due to something with the dye. What are your comments regarding these two
No,
things?
no, but this is a comparison between
Mm,
two groups, right? One that is
yeah,
managed with impeller, one that is managed with without impeller, and
yeah,
they're all cardiogenic shock patients, and you have a statistically higher number of AKI. So, you know, that kind of suggests that it's only related to the impeller group. So that, I mean, that's what randomized controlled trials show, right?
yeah,
Yeah, and this is a good discussion about this study. But the main message is that this study is dealing with the most important endpoint, which is mortality. Many studies
Mm.
now are dealing with a complex endpoints, composites with TLR, mortality, and hospitalization, all of them. And it's raising the numbers is higher. It is more likely to get the significance. But this study investigated mortality per se. So this is a big strength of this study.
yeah.
Okay,
So,
please go ahead.
yeah, thank you. In the end, they devised some algorithm for the use of with the use of mechanical circulatory support device in patient who are having a cardiogenic shock, or in patient who are having a cardiac arrest presentation. So if the cardiac arrest and ROSC achieved, you need to understand that this is isolated LV failure or isolated RV failure with biventricular or either the biventricular failure. So if it is isolated LV failure and criteria according to Palmier right heart cath is appropriable, then they are implanting Impella CP and Impella sometime upgrading to Impella 5.5. And if there is a isolated RV failure, in spite of inotropes with right heart failure, they devised Impella RP in case of right heart failure. And in case of biventricular failure, they devised Bipella, Impella CP, or upgraded to Impella 5.5 plus Impella RP. Or on the other hand, if the patient who got arrested and no ROSC achieved, initiate ECMO after 30 minutes. If oxygenation is inadequate, go for VECMO. Active unloading with the Impella within the first 2 hours after ECMO start, and they did combine with ECMO and Impella CP or Impella 5.5. So my take home is that to optimize the patient care, multidisciplinary interprofessional and institutional protocols for the patient with reduced LV ejection fraction undergoing invasive cardiac procedures requiring mechanical circulatory support should be established. Need for early heart team meeting for risk stratification and management planning that extend beyond the PCI and includes GDMT and treating concomitant valvular disease. A defined minimum qualification for the operators performing high-risk PCI with or without mechanical circulatory support requires a higher level of competence in several techniques, experience in radial access, femoral access with devices more than 10 French, rescue pericardiocentesis, right and left heart cath, PCI in all cases of ACS with multivessel disease, bypass graft, bifurcation, left main PCI, lesion modification tools and rotation and orbital atherectomy, along with calcium treating modalities like IVL, laser, intracoronary imaging, as well as intracoronary physiology, and strategies to manage revas failure and complication with the use of mechanical circulatory support devices. Intra-aortic balloon pump is insufficient in providing hemodynamic support, especially in AMI with advanced cardiogenic shock. Thank you.
Because there's a few things I think we might need to cover. So one was, Holger Thiel's paper in 2023 that showed us that actually ECMO in this cardiogenic cohort, cardiogenic shock patients versus medical therapy, there was no difference in risk of death. So I think that's important. And then more recently, the ESC guidelines being updated to give a class 3 classification to the routine use of IABP and ECMO for cardiogenic shock. Do you want to comment on that? I think that's very important. Two very important aspects in this topic that I don't think you've covered. Would you like to say a little bit about that?
According to new guidelines, just I know that intra-aortic balloon pump is insufficient. It's class 3 now. I didn't find them because I was just focusing on danger shock trial, and according to this, they have concluded that if the patient got cardiac arrest, then if no ROSC achieved, then role of ECMO is initiated. And if the patient got arrest and ROSC achieved, then it will be a combined role, sometimes mostly predominant role with the mechanical circulatory like Impella, and uh, combined with the this ECMO is still, according to danger shock trial, is still not valid.
Yeah, so I think for this topic, there's a few important aspects. So, number one, when you have a cardiogenic shock patient, you need to classify them like you rightly have, and you
Yeah,
need to use the tools that you have available. So, you know, invasive blood pressure, non-invasive blood pressure, serum lactate.
yeah,
You know, some people do right heart. You can get an LVEDP, you know, various ways of getting the information, and then it's about deciding whether or not the patient requires mechanical support, and then which mechanical support to choose and why,
yeah,
and and then, you know, escalation from there. I think those are various important aspects of this big topic. You know, it's quite a big topic, and it's something
yeah,
we as interventionalists face quite regularly. I think danger shock is one trial that, like Prof mentioned, that, you know, had a was a turning point in terms of pointing us towards the use of Impella in this cohort. But again, you know, it's choosing the right patient, not the patient that arrest. And you know, you get ROSC and they're in Sky D shock,
Mm.
and you
There are
put the
too many topics, too many other things to
yeah.
take care of, including the comatose state, neurological
Yes,
impairment,
yes, yes, yes.
and that have
So
prognostic implications.
there's all of that. So I think you did very well. It's just you know, ECMO, I think, is still you know, still a debate. Some people would put patients on ECMO still. Some people are saying actually the data doesn't support. I don't know, Prof. What's the use of ECMO in your center?
Yeah,
Are you
so
guys?
we are huge utilizers of Impella, huge.
Mm,
We use it in many shock patients, and last week in 2 days I did 3 high-risk Impella assisted PCI. So we use a lot of Impella, but also the ECMO is used a lot in the US, I have to say.
mm,
The there is a preference for Impella, I have to say, probably in shock patients 70. But if there is a doubt, about right ventricle involvement, the
mm,
decision is clearly for ECMO. If
mm.
yeah.
not, probably Impella wins easily.
Yeah.
Same, exactly same. Because I did last month, I did locum in one of the university hospital, and this they are King Saud University Center. They are the primary shock center as well, and they are doing exactly the same. In case of only LV failure, isolated LV failure, they are doing Impella, frequently Impella, and sometimes they are combining Impella with intra-aortic balloon pump. So I don't know, they are doing some study regarding for this, or, but they are
Adding,
very less. Yeah, uh,
using together.
they are using together intra-aortic
Oh,
balloon pump
wow.
along with Impella. So
I'm
With
not aware about
Impella.
that. So,
with Impella,
yeah,
Wow.
that's strange. They do the same
yeah.
thing, Impella
Yeah,
does it
this
better.
is something crazy. I was looking at that time, and now they were least interested to for ECMO except if the patient got arrest and ROSC achieved, or especially with the RV failure. So
Mm.
still, I am looking for more data. So we need to standardize our practice in our center as well. So still, we
So
are.
my suggestion would be to start using Impella. It's an easy device. The problem with Impella are related with the bleedings. There is, especially at the beginning, a substantial increase in bleedings as compared to any other tool that we are using in interventional cardiology. So if you take care of the femoral artery with ultrasound guidance in 110% of the cases, which means always,
Yeah,
and if you take care of that also under angioscopic guidance, if you do that as a state of the art, you can deal with Impella. You preclose it, and then you have a much lower risk of having bleeding complications. This has been shown in the PROTECT 3 trial, which you did not mention, but the main message of that study is that if you use well, actually it was not on shock, but we can discuss about that when we do the high-risk PCI. But the main message is that if you assess the performance of Impella in experienced centers, dealing more with the complications related to the femoral access, is working much better than the results of the PROTECT 2 trial.
Yeah.
The final thing I think is having a shock team. I think having a systematic approach to dealing with the shock patients, all the way from your A&E up to cath lab, and then afterwards. That's very important because sometimes you might do all the beautiful work, and then they go to CCU and they don't know how to care for the Impella or the perfusion distally. Then it all just it's a waste.
That's the most important thing. Should be a shock call with a cardiac surgeon, the CICU guy, and the heart failure specialist. That's very important. And I would like also to emphasize the reading of a recently published paper in the European Heart Journal. I recently read it. Let me see. Okay, I'm going to share it. These are guys that are experienced with on shock and MCS. Holger Thiel has published tons of papers. Kierkegaard, I don't know, Dr. Muller. It's a nice paper. It's a synthetic paper. I have to say that linguistically, I was surprised to see such a paper published in the European Heart Journal, because there are, it's not written in a good English. It's not written in a good English, but it's nice. There are nice figures, so I suggest you to go and go through it and read it. It was published a couple of weeks ago, I think.
Yeah. So Jakob Muller is the danger